because this is an African presentation. So I don't think I have to introduce myself to any of you guys. So I'm glad you're here. Welcome to this year's first Global Community Health Grand Rounds. It happens quarterly. And then the first session, I tried to do at least a small introduction to what the Global Community Health Center is and what we do. And then Dr. Jimmy Jones, who also needs no introduction to you guys, will present a case and some of her things that she learned through her clinical experience in Kenya with me in July. So let me find my advancer. Here we are. So we do global community health programming as a part of the curriculum around areas of social determinants of health and healthcare disparities, which is part of your education. But part of my background is in infectious disease medicine, specifically around HIV in Africa. And so this was, I think, a particularly striking slide for me, and part of the reason why we got involved in medical education in the developing world initially in around 2013 and then moving on to present day. So these world mapper things do really cool visualizations. If you look at where are the doctors in the world, there are sort of fat places over here, and then there's sort of a fat place over here. But there's a really skinny place down here. And this is where we did our medical education stuff. And then over here, you look at early mortality, where people die earlier than probably they should. And then there's quite a bit more robust width to these shapes. Little skinny width to these shapes over here. And then, of course, a big burden of early mortality in India. So the impact of medical education as it's visualized in these maps, I think, is one of the reasons that we do what we do. Okay. And here are some of the other reasons. This is one of our core values: academic and clinical excellence to meet the global and community health challenges of today. There are some estimates, and estimates are estimates, but the idea that in 2050, approximately 50% of your clinical encounters will be with someone of a different race or ethnicity than the majority in the United States, 50%. So the fact is, around 50% of your encounters are going to be definitively cross-cultural, but the reality, and one of the ideas behind the Global Health Center, is that in truth all medicine is cross-cultural. Some of you take care of members of my family over time. You know, I've come from a large family in rural Marion County, just west of the Suck Creek Mountain, and it's not at all uncommon for me to make some sort of, this is my cousin twice removed, connection to someone on inpatient medicine Team C. But the reality is their life is very different than my life in Ridgeside Road, Chattanooga. And the determinants of health in their life are different than the ones in mine. In a sense, it's cross-cultural, even though we're in the same family. So one of the hypotheses of the center is that, in a sense, all medicine is cross-cultural. If you have some skills in bridging those divides that can be taught and learned, then you have better outcomes for your patients. It's also part of your curriculum. It's starting to be valued even in the different milestones. This one's just pulled out from general surgery, also reflected in your milestones for all of you guys are internal medicine-y. Okay, but these are the goals that we're wanting to get to. Resident uses a variety of techniques to ensure that communication is understandable and respectful. Resident effectively communicates basic health care information, customizes communication, taking into account patient characteristics, including culture. Those are harder to attain and harder to measure than we know how to do right now, but they're aspirational goals for the program and for the center as well. Okay. So this is kind of our mission statement, that we exist to prepare healthcare workers to serve in global community and to work in global communities. All right, and that's what we do. Part of the way that we do that, there are several arms to what the center does. We do didactic grand rounds types of experiences like this one, where we bring speakers in to address topics of interest in global and community health. We do clinical experiences, facilitating learners in East Africa, in Kenya, where I go about once a year with one of the PGY3s. We also are building some other community health, rural medicine types of clinical experiences alongside one of our new faculty who's coming in October. It will be in Grundy County, Tennessee, which has approximately the same health outcomes data as Sierra Leone. So there are a lot of things to learn there, and a lot of things to have really a cross-cultural experience in. So those are the experiential things. We do some additional education and training within the Global Community Health track that a couple of your colleagues here are helping us to get up and running, Dr. Abdel Gadir and Will Zabala. And then we also partner with some research partners, with one of our goals being to produce first author publications from national trainees in the countries in which we work. We have a paper that's in consideration from a Burundian colleague on healthcare attitudes and practice regarding antimalarials. So that's kind of an overview of what we do. And we're also open to your ideas and your stories. Some of you have very interesting experiences, and would love to capitalize on them in the center as well. So one of the things that we do with the Global Health Electives is that we ask you to present from your experience and to tie it to a topic of that's known, but experienced in a different way, in a different context. And so I would like to introduce Dr. Jamie Jones, who needs not a lot of introduction for you, but you weren't there for the 4 weeks we spent together in very close proximity in a rural part of East Africa, and I'm really grateful for her willingness to learn and to be stretched and challenged. And I believe that she had a wonderful experience. She definitely did a great job. So she's going to present to us about diabetes and some of the unique challenges of diabetes in rural East Africa. So here's Jamie Jones.
Okay, bear with me now. I don't like talking in front of people, but it's pretty much our program, so it's okay. So my topic is on diabetes in sub-Saharan Africa. As you know, I was in Kenya for 4 weeks in July with Dr. Davis, and you know, one of the things that I'd asked around, like, what is the most common thing that I'm going to see? And a lot of times they're like, oh, you'll see a lot of infectious diseases, TB, malaria, things like that. But one of the things that struck me is how many people had diabetes and hypertension. And I'll get into some more information on that. But that's one of the reasons why I chose this topic. My objectives, we're going to talk about diabetes in the sub-Saharan Africa, discuss specifically ketosis-prone diabetes. You know, we always hear about type 1 and type 2, but then you have these patients that are type 2 diabetes, but they'll present in a DKA. And so it's a little bit atypical from what we're used to. And I found it pretty interesting because we actually saw a couple of these patients over there. and then also talk about the challenges of the healthcare in global areas, and specifically rural Africa where we were. So in case you don't know what sub-Saharan Africa is, pretty much most of the countries in Africa is south of the Sahara Desert. The only ones that they exclude are Algeria, Djibouti, Egypt, Libya, Morocco, Somalia, Sudan, and Tunisia. So I had to kind of really look it up because there's not a ton of data in certain countries there, just because there's not a lot of healthcare and a lot of centers for that. So it's kind of difficult really trying to find information on this specifically over there. So a lot of it is just from studies done in other countries, but it's kind of correlates with that. This is my outline. I'll talk about a case presentation, talk about types of diabetes, talk about specifically ketosis, and then barriers. So we had a 48-year-old male with history of insulin-dependent diabetes and hypertension. He came into the hospital. He had a 2-day history of increasing thirst, increasing urination. He was kind of confused. And that day, he was more lethargic per family. The family said, you know, he took his insulin every day. He had been in his normal state of health. He wasn't having any illnesses recently. He was very compliant. He went to the doctor, all of these things. The review systems was essentially negative. History, diabetes type 2, hypertension, no surgeries or allergies. Medications were mixed hard 70-30. He took 26 units in the morning and 12 at night, and then Allopril. So that's another thing I had to get used to in Kenya. No one can afford your long-acting insulin there. And also, nobody does pre-meal insulin either. It's very rare that you actually find someone that could check their sugar 3 times a day, let alone once a week. So they used a lot of mixed hard, which is essentially your MPH 70-30. So that's what we used for mainly all the patients. And then the ACE inhibitor that they had was an Allopril there. So blood pressure 112/84. He was tachycardic, increased respiratory rate, but sitting well and room air. Another thing I learned is they say, you know, we say a gentleman's lying in bed in no acute distress. They call him fair general condition is one of the lines that they use a lot. Slightly confused, lethargic, but he was arousable. He had rapid, shallow breathing. I meant to change this. He was arousable, so he was more alert when he was arousable. But he was a little disoriented following commands. He was tachycardic, and really the rest of the exam was benign. Also, another thing is there's no BNP or CNP. You have to ask for specific blood tests. So sodium was 131, potassium 4.5, chloride 104, bicarb 10, glucose 19. They also use a different system with our glucose. We use milligrams per deciliter here. They use millimoles per liter. So normal glucose is like 6. And, you know, for us, we're like, oh, no, that's way too low, but that's normal for them. So glucose was 19, which is about 342. His UA was positive for ketones, a couple of WBCs and RBCs. Serum WBC was 12 and hematocrit 33%. So you can see here he had an A9 gap of 17. He had ketones in his urine, and he had hyperglycemia. And those are the main things that they use with clinical history, things like that, to diagnose DKA. So this guy, he was admitted to the ICU. He was treated for DKA. He was given lots of fluids, started on an insulin drip, and monitored until his sugars became more controlled, his gap closed, and he was more awake and talking. And when we talked to him some more, you know, he said, I'm very compliant with my insulin. I actually show up to the clinic. I get refills when I need them. And then one thing you don't think to ask is, well, where do you store your insulin? Here, we all have a refrigerator we can store insulin in. But he told us he stored it in a charcoal box. And I had to look up what a charcoal box was, and I'll show you a picture of it later. But apparently it's used for refrigeration a lot in Africa because the charcoal has pores and it's able to keep things cool. So that was just something interesting. But we don't know for sure if that was proper refrigeration, so that's what we kind of suspected maybe that triggered this. But the main thing with this patient is he's a type 2 diabetic that presented in DKA. And that's kind of what I'm going to talk about a little bit. I know we see patients here sometimes that, you know, they're HHS, usually with type 2, but sometimes they may have like a ketotic component to it. So that's just one thing that I found interesting about this guy. And, you know, we actually saw more than one of these types of patients over there. And Dr. Davis and I were just, you know, kind of scratching our heads like, what's going on? So that's something that I wanted to kind of dive more into, which may be too much because it's not really well understood. There's a couple of different studies and a couple of different classifications about it, which I'll talk a little bit about. But it's just pretty interesting to me how we're redefining it every single day. Like things that we knew, we're finding out more information, and we're already, you know, reclassifying things. So why should we care? So diabetes is here. It's everywhere. All of our patients have diabetes here. We're always, you know, treating patients with hyperglycemia, with kidney problems. They have diabetic foot ulcers, retinopathy, all these complications. Like that's something pretty well known here and that we see every single day. But it has now become more prevalent in Africa in general. And kind of the question is why. So there's just articles everywhere, like burden of diabetes set to increasing at alarming rates. This is estimating, you know, the burden, and another thing is it increases death and it increases cost of health care. And then, so these are just a few articles that I found just on this topic over the last few years. So it's being talked about, but in some of the countries, they don't have as many resources, but Kenya actually has a national diabetes guideline, which not all of the African countries do that. Here we have the American Diabetic Association. We literally have all sorts of resources and support groups and things like that, but over there it's really not there. So I took this from healthdata.org. This was actually one of my topics that I was supposed to do with Kenya. I was supposed to look at what are the top 5 causes of death from 2007 and 2017, and then also see what's kind of on the rise. And if you look in the red, they're all communicable diseases. That's the main things that you see over there. You see HIV, you see AIDS, you see TB, you see, you know, infectious type things that are easily spread to each other just because of sanitary conditions or living conditions, things like that, which, you know, it's improving, but if you see where diabetes is, it's number 14th, and then you see that it increases to number 9 as one of the top causes in 2017. And obviously the deaths are going to be more related to the complications, like your retinopathy, not really retinopathy, but your nephropathies and your ulcers and infections and stuff that come from it. So I only chose 3 countries because that really, there's not a ton of data when you look at this. You know, the problem is you have to know you have diabetes to be able to have information on it. So pretty much, I was reading about half the people in Africa that have diabetes don't know that they have it. So it's kind of difficult to really get concrete data about this type of stuff. But Kenya was one that did have some data about it. South Africa as well. You see diabetes, and you even see COPD down here, strokes, ischemic heart disease, all those risk factors for vascular disease. And then diabetes moved up to number 5. And then Zimbabwe as well, number 11 up to number 9. So these were the main ones. This is just to illustrate, like, the main causes of death, you know, usually your communicable diseases, your infectious diseases, but non-communicable diseases are on the rise. And that's the most common here. We have stroke, and this is the United States. So we have ischemic heart disease, Alzheimer's, lung cancer, stroke, COPD, all these things that are non-communicable. Like these are things that whether they're smoking or they have high cholesterol or high blood pressure, and some of this is from like risk from genetics. Unfortunately, we can't change that, but it's a lot of modifiable things that we can do on the rise. But here, diabetes was number 8, and it's actually decreased to number 9. So I think we're doing a better job here in the States, but I guess this is where we can maybe apply some of what we do here over there, except we can't really just because of resources there, which I'll get more into. So I'm just going to give an overview. I know everybody knows what diabetes is and the different types. So, but this is just like a simple overview, and then I'll get more into the ketosis-prone diabetes. So type 1, obviously, it's mainly destruction of your beta pancreatic cells that lead to like an absolute insulin deficiency. So all of these patients need insulin because you don't have your beta cells to secrete it. You have your type 1A, which are your normal autoimmune antibody ones. And then you have type 1B, where you don't have antibodies, but you have the destruction of your beta cells and your insulin requirements. So they call it kind of idiopathic. And then you have your latent autoimmune diabetes in adults, where it presents a little bit later. You have autoimmune antibodies, and you may not need insulin first, but it usually progresses to destruction where you're going to be requiring insulin. And you have your type 2 diabetes, which is more of your obese patients with insulin resistance, and more characterized by your hyperglycemic episodes. And then they have varying degree of insulin requirements. You could be on your orals, or they may progress to requiring insulin. And then you have your ketosis-prone diabetes, which is kind of underneath the type 2 diabetes, where phenotypically they're obese, they may be on metformin, and then all of a sudden they come in ketotic state. So they finally just reclassified, like kind of labeled this whole group as ketosis-prone diabetes in the past. I don't know if you've heard of Flatbush diabetes or atypical diabetes. They've kind of seen these things in the past, but this is the first time that they really were able to kind of group it all together. And there's still some data on it, but it's still not really well studied. And then I'm not really going to go into the genetic defects and then the gestational diabetes on these. So ketosis-prone diabetes, you have severe beta cell dysfunction, not destruction, in a variable clinical course. So this is saying that you have dysfunction of your beta cells, so you're not having the insulin, which makes you require insulin, but the clinical course can be variable. Some of these patients may require insulin, and then later on, they're not lifelong requiring insulin. They can be on orals, which is what was scratching our heads, where these patients come in DKA, you give them tons of insulin, and then you discharge them on metformin. So that was what was interesting to us and one of the reasons why. And there's a couple of different systems, and I think this is where it gets super complicated, is that there's different types of systems to try and classify these. So the first one is the American Diabetic Association system. So this one kind of just says, you know, your type 1 is your autoimmune destruction of pancreatic beta cells. You have no insulin. You have an absolute requirement for insulin. And then you have, you know, you measure your GAD or your ICA antibodies, and then they usually present in DKA because they have this insulin deficiency. And then you have your idiopathic or type 1B that don't have the antibodies, but they still have destruction and requirement. And then you have your type 2 patients that are obese and that become insulin resistant or insulin dependent. So these are systems based just for ketosis-prone diabetes. It's not for just other ones, but it's mainly just to classify this. And the reason why they classified this is to figure out who's going to need insulin later on in life. They don't really know who's going to need it. It's just kind of only time will tell kind of thing. So the modified one is one I'll talk about in a little bit because there's a paper done for this. But pretty much it was in France, and they used this system, and they did it into 3 groups. One had the type 1A, where you have the antibodies, where you're ketosis prone. So you have antibodies, absolute deficiency, and then you have insulin requirements. And then the second type are your ketosis prone, diabetic, insulin dependent, and then non-insulin dependent. So pretty much these are your type 2 type of patients that present in ketosis, and one will require insulin lifelong, the other ones won't require insulin lifelong, which I'll talk about that in a paper that I read and kind of got some of this information from in a minute. Third one is BMI based. Pretty much it separated them into either they're lean, the BMI was less than 28, or they were obese where it was greater than 28, and that's just kind of how they classified these ketosis patients. And then the last one is autoimmune antibodies, and then your beta cell function, which I actually talked to a little bit, because I found this one a little bit easier to look at it, because if you look at it, either antibodies are present or not, and then either your beta cell function is present or not, which is what this says. So the first two are going to be more like your type 1 diabetics. You either have antibodies or you don't, and then, but you have no beta cell function. So you have typically destruction, so you're insulin dependent. So these both require insulin because you're insulin dependent. And then the last two, you either have antibodies or not, but you have preserved beta cell function. And then you try and figure out whether or not they're going to need insulin later on. So initially in the ketotic state, they have reduced beta cell function, and then, but it's still present, and then you have to figure out whether or not later on that they're going to need to have insulin. But the one I have highlighted is the last one. So this one makes up the majority of your ketosis-prone diabetes, and then they actually have a higher rate of insulin discontinuation at 6 months. So the ones that don't have antibodies and their beta cell functions present, they, and that go into a ketotic state, they have a higher rate of discontinuing insulin and being non-insulin dependent. Okay. So this is the paper that I was talking about that used like the modified ADA system. So pretty much what it says, ketosis-prone type 2 diabetes in patients of sub-Saharan African origin. So this was actually done in France. This was not done in Africa, but they took patients that were originated from Africa and that presented in ketotic states. So pretty much they're trying to say that you can determine who is going to require insulin later or not by their epidemiological, clinical, and metabolic features at onset, and then they actually measure their insulin secretion and action during a 10-year follow-up. So pretty much when they first presented, they would ask, their family history, whether they had a family history of it, whether they had diabetes in their parents or in their siblings, whether or not they obviously they measured their BMI with obesity, and then they also measured whether it was new onset or not. So your type 1 diabetics were already known as the ones that they used, and then the type 2 diabetics, it's usually their first presentation. They presented in DKA, so they don't know if they're going to require insulin or not. But I thought what was interesting is they used the C-peptide as a marker of whether or not their body was secreting insulin. And they kind of measured the change in the increase of it over a 10-year period. And that was kind of how they marked whether or not their beta cells were kind of perking back up. At the point, they had lower rates of C-peptide because for some reason their beta cells were just not functioning and they were not secreting their insulin. And that's one thing that's not really well studied is they don't know why during that episode they're not, functioning. And then later on, they measured it, and they figured out that, the ones, the ketosis-prone diabetics, they had more males, they had a strong family history, and they had a higher age and BMI. But what was cool is that they actually were able to discontinue insulin in 76% of those patients. So, and then they may or may not have ketotic relapses, but what the ketotic relapses were associated with more frequent episodes of hyperglycemia. So pretty much if you weren't controlled, then you would have a higher rate of ketotic relapses. But this was interesting because, you know, it tries to make you or help you kind of figure out, okay, yes, these patients, this is how they presented, but what are some things about the patient that we can kind of predict whether or not they're going to require insulin or not. So I thought that was interesting that they used the C-peptide to kind of, you know, measure that along it. But there was one of the results did show that they actually, some of the patients that actually ended up not requiring insulin, they had like a 80% change in the C-peptide of improvement in their beta cell function. So, you know, it's not, like I said, it's dysfunction, not destruction, where you're type 1, you're going to have destruction, and they just absolutely don't work, and they're not coming back. But in these patients, there's something going on that makes them kind of stop working for a minute, and then they kind of perk back up and start working. So with all of that being said, one of the things is that was difficult is barriers to health care. And actually, Kenya, where we were, they have an actual diabetic guideline, and it's very, very long, but a lot of it was based on diabetic self-management. And so pretty much educating the patient, letting them know what to eat, what to drink, how to check sugars, all of these things. And I actually did like a little presentation on it with the Kenyan guidelines, which actually they use a lot of our American diabetic guidelines to kind of help form those. But they, you know, when I was discussing what the recommendations are, we were talking like, okay, this says that you should check your sugar 3 times a day. How many of your patients check their sugar 3 times a day or actually have a glucometer? And most of them said, well, if they actually have a glucometer, they will check it, but most of their patients don't have a glucometer. Plus, you know, metformin's pretty cheap over there, and the Mixtard is cheaper. But I was looking at prices for Lantus and Mixtard, and Mixtard's like, I think it's about $4 for a 1,000-unit vial, whereas the Lantus was about $40. And that could be someone's whole salary for the year. You know, that's how poor they are and how, you know, they're not able to afford these things. Even though that seems like a small expense, that's a big expense for them. So that was one thing we had talked about. And then with education, obviously, educating patients about it, you know, and bringing awareness, because it is new, it is on the rise, but a lot of patients don't understand there's a little health illiteracy when it comes to this. And plus, there's not that many doctors there anyway that are able to, you know, spread the word and kind of do this. And also educating with screening. You know, you kind of have to screen these patients to really know if they have it or not, or they actually show up just super sick, and that's when they first find out. So, and that's where the focus on preventative medicine instead of acute health care. A lot of times those patients, you know, they don't go to the doctor unless they're really, really sick. So trying to shift the focus from acute to preventative, which also lack of resources is a problem. And then financial barriers, which I talked about with the insulin, and then national diabetes programs. I know Kenya has one, but it's relatively new, maybe in the last 2 years probably, but not all countries are able to do this. So these are just some of the barriers of treating diabetes and really getting a hold on, like, with increasing death from this. So these are just generalized barriers. So another barrier is for healthcare providers and actually being able to give the appropriate health care to patients. We were lucky. We actually had an ICU in the hospital we were at. We were able to give fluids. We had insulin pumps. We had, you know, more than most places did. But one of the things, so this is the charcoal box. I had to Google what it was. This is just something that I found on the internet. It's not his charcoal box, but this is kind of what it looks like. So pretty much it's like chicken wire in a wooden frame, and they put charcoal in there and they have it shut, and it looks like they have like a water system around it, but apparently it's supposed to keep things cool. And I actually read about it. They keep a lot of produce and stuff like that in rural parts of Africa, but it was the first I had ever heard of it. So that's, you know, one thing that you don't think to ask. But this is one picture of a ventilator in the hospital we're at. It's German, so they actually had to put English labels on everything there. But there's no respiratory therapists, there's no pulmonary critical care doctors, there's no one managing this except for you. And so that was one barrier is, trying to deliver health care in a different language and different machines that you're not really used to. This is a picture. I had the privilege of going to a rural clinic called Cabazon, and I got to ride in the back of this ambulance with all of these boxes about an hour on really bumpy roads. But lack of supplies is another thing. So all these boxes are actually HIV medications, and they're being sent out to this little clinic, which is what I'll show you. There's no doctor out here. They have what a clinical officer is, which is like a PA. And he literally runs the entire clinic by himself at all hours of the night. He could be seeing the patient, run over to registration and register them, go to the lab, draw their blood, and then go to the pharmacy and distribute their medications. So I got to go out there one day and kind of help out. And it was definitely an eye-opening experience because it's literally one person running this entire clinic. And it's kind of out in the middle of nowhere, too. This was our one EKG machine in the whole hospital. And you were lucky if it had paper in it. And if you needed the stickers, you had to go to the pharmacy and get them. And another thing is the patient had to pay you for them before you could get the EKG as well, unless it was an emergent situation. But a lot of the patients, if it wasn't a serious illness, like if they weren't pretty much essentially admitted to the ICU, they had to pay up front for their admission, or the family had to go gather funds. Literally, they would be like, oh, we don't have enough money to pay for this admission. Let me go try and raise some money, and then we'll be back, which that was kind of new. But if there was an emergency, then they were able to kind of bypass it a little bit. Or just imagine you had to walk to clinic on this road, miles and miles, just to go to the doctor to get your medications refilled, which a lot of people did do that. So this is just one of the back roads in the area we're in. So these are just little things that we don't think about here because we have a vehicle, or we actually have a bus, or public transportation and things like that. And then this was our group that we had with Dr. Davis. It consisted of mainly interns. They were either medical officer interns, which means they went to medical school, and they have to do this 1 year of internship where they rotate through everything, which is like a transitional year in the States. And then they had not compliance officers, clinical officers, which they finished their CA school, and they had to do this internship. So this was the group that we were with pretty much the whole 4 weeks. And here's my references. Any questions? Sorry. Oh, I did want to say this. So the question is, why are diabetes increasing in Africa? Somebody asked me that yesterday when I was practicing. So a lot of times one thing that I found interesting was there is an increase in processed foods. I saw processed food wrappers everywhere, even in the rural areas. There's chips and candy and crackers and all sorts of stuff. So I think with urbanization, that's increased. There's probably some genetic factors. There's just a couple of different things that have just made an increase in diabetes, which is a risk factor for heart disease, and then you have your hypertension, all these things going into all of these non-communicable diseases that are seen on the rise there.
How popular is Coca-Cola or other soft drinks?
Yeah, so they have them there. They had them at the little Dukas right down the street, and they're like 20 cents. So you would go get a soda and drink it, and you bring the glass back. So it's relatively popular. The main things I saw were Fanta and Coke. Those are the two sodas there. Yeah, so that's another thing. Yeah. And they love their chai tea, which has a lot of sugar in it too. So. And mandazis, which is just fried bread, essentially. Yeah. Huh? I know, because Chai is T. It's the same thing. So what used to, like, was called like flatbush or atypical, they now grouped it in ketosis prone. So. Yeah, So it's this. They now just group it into ketosis prone. So that's just what it was previously like kind of labeled. So yes.
What is regulation of medications like there? Are insulins widely available to those who have the means to obtain them, and how do they distribute them?
Yeah, I mean you have to go to the pharmacy, but yeah, you have to have a script for it, obviously. But, I mean, I don't think, we never ran out of, they never had shortages in the pharmacy, but if they had the means, then it was available, if they would come and get it, obviously. But I think it was pretty available where we were at, so. Yeah, I was about to say, this, yeah. Yeah, so, yes. Yeah.
The fact that Lantus is available is just like a mousetrap with golden bow tie around.
Yeah. No, it's true. MPH is good because you kind of get your pre-meal insulin plus your basal when you give it twice a day. But we had patients that were difficult to control because you're like, oh, well, they're spiking in the noon. We need to give them pre-meal, but they're not able to really do pre-meal. I was rounding one day. I was like, oh, yeah, let's start some pre-meal. And Dr. Davis is like, they don't do that here. Okay. I was like, okay.
Yeah, I agree. So it's about to retrain
Yeah.
the people to go because they're never used to it.
Yeah. But no, it was no, it was a good insulin. It was like perfect for them. It was twice a day, and you adjusted it based on their sugar. In the hospital, it's obviously easier to adjust, but in the clinic, it was more difficult unless they actually checked their sugar. But
So I said we were going to finish on time. Thank you. A little early. Thank you.
yeah.
Please eat lots of food because I need to test your beta cell function. And there's a lot of food there.
Thanks. Well, I'm like sweating right now. So.
I'm not saying it's comfortable for you, but
Yeah.
you can do it. So you do nice to you.
Yeah. Yeah.
I was wondering.